Does cannabis put you at a greater risk of developing schizophrenia? Is it safe to use psychedelic-assisted therapy for psychotic disorders? Is there a difference between the psychotic experience and the psychedelic experience? In today's episode of the Psychedelic Therapy Frontiers Podcast, we're going to discuss these questions as we explore the fascinating topic of psychosis. For those of you who are new to the show, welcome. Psychedelic Therapy Frontiers is brought to you by Numinus and is hosted by me, Dr. Steve Thayer, and my co-host, Dr. Reid Robison. Just a few announcements for you before we get into the episode. If you're looking for professional training pursuant to becoming a psychedelic-assisted practitioner, you can check out the courses we offer here at Numinus. Go ahead and click on the link in the show notes, or you can go directly to numinus.com/training. There you can use the code PTF10 for 10% off selected trainings. If you've listened to our show for a while, you've likely heard Reid and I talk about the psychedelic clinical trial work that Numinus does. If you or someone you know might be interested in being a participant in a psychedelic clinical trial, you can click on the link in the show notes or go directly to numinus.com/research, where you can learn more about the trials we're currently running. If you're a fan of the show, if you're new to the show, and you'd like to support us, here's how you do it. Please leave a rating or review in places like Apple Podcasts or Spotify. If you're watching on YouTube, like the video, subscribe to the channel, comment below, and maybe share the episode with somebody you think might enjoy listening to it. Without further delay, here's today's episode on psychotic disorders, psychedelics, and cannabis. All right, Reid, we're at it again. Another episode of Psychedelic Therapy Frontiers. We're going to do a kind of a shorter one today. Shorter is relative,
we
I guess.
always say.
I know. Then we just can't stop our gums from flapping. But today we thought we'd talk a little bit about psychosis. We've sort of referenced psychosis, psychotic disorders a couple times on the show, but thought we'd give a little dedicated talk to psychosis, some of the different diagnoses, and then talk a little bit about psychedelics relative to psychotic disorders. So maybe we start with, go ahead.
No, this is it's a fun topic, I think. I've worked with psychotic disorders in pretty much every way possibly clinically, like schizophrenia studies, using ketamine as a model of psychosis in studies, but I've also done psych consults in the ER here in Utah, in Utah's biggest hospital, IMC. Did that for a number of years, which was fascinating to see both the psychotic breaks coming from psychotic illness and substance-induced psychosis come through. So anyway, I think it's something I can geek out on for sure.
Yeah, depending on the career path, I think psychiatrists tend to get a little bit more exposure to these sort of serious and persistent mental illness than psychologists do. Again, depending on the career path. I think I had most of my exposure in graduate school and early career. And I don't work clinically very much with psychotic disorders or serious mental illness anymore. So in prepping for this episode, it was reminding me just how fascinating, of course, tragic for those people who either have these diagnoses or loved ones who have these diagnoses. But it's also, got into psychology in part because I was so fascinated by the human mind. And this is some of the most fascinating stuff with respect to the human mind. And when people think about psychosis, they often think about, sort of the more prominent, publicly understood diagnosis, and that is schizophrenia, right?
Yeah, and I'm glad you're pointing that out, the compassionate preface here, because I think it is possible. It certainly is possible, and we want to iterate that we're trying our best to do that, to hold all the compassion and empathy in the world for these debilitating conditions, and curiosity about the human mind and what can go awry. But I feel for individuals, like 1%-ish of the world will get schizophrenia. And if that hits you or your loved one, think of the implications on one's life. And that's actually one of the things, kind of one of the big driving forces of getting into psychiatry is this unexplored frontier of the human mind, and how helpless we feel as individuals, family members, and clinicians in treating and supporting some of these conditions. Like schizophrenia, we can talk about the treatment, but to suffice it to say that there's no cure for schizophrenia.
Right. Yeah. So maybe by way of just sort of covering some of the terms and definitions, psychotic disorders, including schizophrenia, usually have a couple of things present. And these are things like delusions, hallucinations, disorganized thinking or speech,
Yeah.
disorganized or catatonic behavior. And then there's this distinction between positive symptoms and negative symptoms.
Yeah. Maybe we could expand on these. I think they're important. I love laying the foundation with good definitions like delusion. I remember from psychology and med school and everything, the simplest definition for me that stuck was a fixed false belief.
Mm-hmm.
Just easy to remember that, someone has a strongly held belief that's not influenced by logic or evidence, and it can often contain themes of paranoia or grandiosity. Those are types of delusions, like paranoid delusions or delusions of grandeur, for example.
Yeah, or delusions of reference, thinking that things out in the world are in direct reference to you. And like you said, they are fixed. We've talked a lot about psychological flexibility and inflexibility, especially with reference to psychedelics and other conditions like eating disorders or obsessive compulsive disorder. But this is an example of kind of the most inflexible kind of thinking.
Yeah.
Like you said, delusions are not easily updated by logic or evidence.
And to even back up a tiny bit, psychosis, my favorite working definition is loss of touch with reality, or
Mm.
an amalgamation of psychological symptoms or phenomena resulting in this loss of touch, loss of solid contact with reality. And it's interesting because it's a common feature to not just psychiatric conditions, but neuropsychiatric ones and neurologic ones. What is the difference between delirium and psychosis, and what is how does the psychotic state differ, or how is it the same as the psychedelic state? Right, we'll get into that. But so not only is psychosis the hallmark of schizophrenia, but it's an aspect to mood disorders like psychotic depression, or a feature of mania, like when someone has bipolar, if they have a full-blown manic episode, it can and often is mania with psychotic features.
Right. So psychosis is not exclusive to schizophrenia. And then sort of it also begs some interesting questions about the etiology, like what causes it. You mentioned neurological disorders, and there are some things that we know about the brains of folks with psychotic disorders, especially schizophrenia, like really large ventricles or impaired dopamine signaling, or dysfunction in the hippocampal regions of the brain. And but still, it's not what causes things like psychosis and schizophrenia, like all things in mental health, is still a bit of a mystery.
Yeah, and it's also fun to explore this topic because of the mystery of what is reality, right?
Mm.
Like, if psychosis is a loss of touch with reality, who's to say what is real? Like, just to paint this picture a little bit, there's this book that I like called The Two Christs of Ypsilanti, and
Mm-hmm.
it's about these two Jesuses, or would you say Jezi,
Geez,
perhaps, dueling Jezi on the psych unit. Like, what happens when each person has this firmly held belief that they are Jesus in close quarters? But it's an interesting conundrum, if you will, as a clinician, to come in and explore: is this a delusion, or is this someone who is really being like stalked, or like, is there really surveillance on this individual, for example?
Yeah, like the persecutory delusions, right? The people saying that I'm being tracked by the CIA. It's not that that's impossible. I mean, it's like with when we talk about conspiracy theories. Sometimes the conspiracy theories end up being true. The dueling Jezi is kind of funny. If you've ever worked on an inpatient psych unit, this some of the it's often that delusions take sort of these religious themes. And I mean, I've got a friend who works on an inpatient psych unit, and he'll say it's not uncommon for a couple of Gezi, a couple of Jesuses to get in the same room, and his observation is that they often get along pretty well, actually, kind of sharing notes on their
Yeah.
divinity.
Yeah. And then there's also this thing called folie à deux, and there are even forms of it beyond uh, the delusions shared by two people. Folie, it's a
Mm-hmm.
French term, shared madness or madness of two. And um, so I've seen that come in, like two sisters admitting to the psych unit, sharing this same delusion, like very significant one. And I will say, even though it sounds like a conundrum, um, reflecting on my career and then just in general, it's not hard to tell in the real world as a an experienced clinician working in your lane, if you have, especially if you have time to, like, the answers will become evident over time if you're questioning if something's a delusion or not. And there's all this other stuff, like if there's co-occurring disorganization, like confused, illogical, incoherent thoughts, again, not just in a moment of panic, but persisting. Uh, and I guess that brings up another point I want to make is we can all look psychosis in a split second or a moment, and these things are, like we said about the delusions, strongly held fixed beliefs, but the other things do show up over time in a variety of contexts.
Right. Yeah, I like the point about the presence of other symptoms as well, right? If you might have somebody come in with delusions like we're describing, but maybe also have visual or auditory hallucinations, right? Seeing things that nobody else is seeing, hearing things that nobody else is hearing. Or you might have something like catatonia, right? Somebody's just in a stupor. They're not talking, they're just staring into nowhere, or some of the really fascinating ones are like waxy flexibility or posturing. So
Yeah.
posturing being like they'll maintain sort of this really awkward, uncomfortable posture and won't move it. They'll hold their arm in the air for hours. Or waxy flexibility, you can move them kind of like a wax sculpture. You'll move their arm and then it'll maintain the posture wherever you moved it.
Yeah, the posturing reminds me of just how interesting that the categories are that you mentioned of positive and negative symptoms. The positive being the, like, overt uh, hallucinations and behavior, but a negative symptom could be this flattening or this stuck in a posture for a long time, related in some ways to catatonia. I remember seeing some folks coming into hospital psych units with catatonia where they are just locked in for days. And man, like, looking at that kind of condition and thinking of the person's experience through it is, it's hard to put yourself in their shoes in that state.
Mm-hmm. Yeah, other positive symptoms that along the same lines, like echolalia or echopraxia, where they're just sort of echoing back something that is said, or they're mimicking another person's movements, or sort of these odd facial expressions, intense grimacing that they hold.
Yeah, yeah. So it might help to go through some of the different psychotic disorders, just a brief fly through, perhaps,
Yeah.
because if you look at the prevalence of psychotic disorders in general, um, it's what, 1.5 to 3.5% of people in their lifetime will meet the diagnostic criteria for a full-blown psychotic disorder. But this doesn't mean psychotic symptoms or even
Mm-hmm.
a psychotic break or a psychotic weekend. A significantly larger percentage will experience at least one psychotic symptom in their lifetime. Much,
Mm.
much higher percentage. But so if we go through, we mentioned schizophrenia. Um, that is like, A Beautiful Mind is a well-known artistic depiction of it, the movie, um, and of schizophrenia. But there's also schizoaffective disorder that is, like, basically schizophrenia co-occurring with the mood disorder, typically bipolar, but a depressive or manic. Um, and you land on this diagnosis because the psychosis is still there when the mood episodes are not.
Right.
For example.
Yeah, it's a period of psychotic symptoms, I think, that occur at least 2 weeks without the mood symptoms.
Yeah. And in schizophrenia, there's also that time component that we were alluding to. At least 6 months of symptoms, but at least a month of these what you would call active phase symptoms of like in an overt full-blown psychotic episode. But there's also brief psychotic disorder, like when there's symptoms. And this is probably the most common thing we'll see coming into substance-induced psychosis and brief psychotic disorder, where symptoms are just there for less than a month and there's full recovery, but perhaps suggesting a risk of further psychotic illness,
Mm-hmm. Yeah, and then there's schizophreniform disorder, which is kind of like, I guess, schizophrenia light, right? It's symptoms lasting more than a month, but less than those 6 months needed for the full schizophrenia diagnosis.
Yeah, and to be determined again over time. People's diagnoses change because we don't understand these perfectly, and because they do emerge over time. Like the first psychotic break is typically in one's 20s. It's a little different for males versus females, but there's certainly a population at risk for getting psychosis or a psychotic episode, and that can be unearthed by certain risk factors, engaging in kind of risky practices like substance use if you're at risk, and we can talk about that as well. But that's one of the first things we'll look for when we see psychosis presenting in any clinical setting is this substance induced or not? And pretty much every psychotic diagnosis will ask that, or have that not better accounted for by substance-induced psychosis or a general medical condition.
Right. Yeah, we should. We'll pivot there in a second, because there's some interesting things we could say about substance use and psychosis, and then of course psychedelics. But I guess just to round out the categories here, delusional disorder. We talked quite a bit about delusions a minute ago, but this is where delusions are present, functionally impairing, sometimes, I don't know, manic or grandiose, like we were discussing. But there's no real prominent hallucinations, or they're only directly related to the delusional theme.
And it's interesting in that condition, most of your psychosocial functioning is still intact.
Yeah.
You're functioning at a different level than an individual with schizophrenia, for example. And there's a wide range of kind of the full expression of kind of adult human life activities that one can engage in with schizophrenia. It depends on the severity and the stage of illness, and if treatments are helpful or not. But yeah, in delusional disorder, you might not know it in an individual, but it's hard to conceal schizophrenia.
Right. Yeah, I mean, those are the major categories. I mean, we have like psychotic disorder due to a medical condition. You mentioned substance induced, but am I missing any? I mean, we have.
Well, I think the prodromal state that we used to call it more is worth mentioning, because it's kind of over the past couple decades emerged into a full-blown diagnostic construct of itself, like a clinical high-risk state for psychosis. That's sometimes called psychosis high-risk state. And the goal of really all the research that's been going into this is to help catch psychosis earlier and intervene and understand it better. Like, it's a critical phase for early intervention. But another reason is we'll often see people presenting in clinic with subthreshold symptoms or prodromal symptoms. Like, you start to see some early warning signs, some flickers of a potential psychotic illness like schizophrenia. But you need to watch over time to see what happens. And because psychosis can be debilitating and even unsafe, we want to also watch and wrap around the right level of support for an individual and monitoring and safety checks.
Right. Yeah. So as the clinical understanding and science continues, maybe we get more precise and better at catching some of those prodromal phases. And like you said, it gives an opportunity to intervene earlier. Not that, like you said at the beginning of the show, not that these things are necessarily curable, but like with most mental health issues, early intervention is better than late.
Yeah. Yeah. And then I guess before we get into the links between psychedelics and psychosis and cannabis and psychosis, just this foundational question of what is reality intrigues me, because you can be out of touch with reality, like we're talking about, but can you be too in touch with reality? Maybe I'll pose that question to you, Steve. Like, what's on the other end of this spectrum?
Yeah, that's a great question. I mean, I think a lot about what is reality when I'm in a sort of an existential mood, but too in touch with reality. Huh.
And I guess by that, maybe I'm like thinking of over control conditions, or this spectrum of disorder in the universe and order. And that we as humans with cognitive flexibility, like you mentioned, like to be able to swing on this pendulum within the bounds of not too out of touch, not too far from reality that we can't grab onto it and we're lost, or not over controlled, hyper focused on our subjective reality being real, like our subjective reality, meaning our image of ourself, for example. Like, to throw an example, could be in eating disorders, body dysmorphia, or over control conditions, OCD. Like, the germs start to, the fear of germs and the behaviors we engage in to avoid that can be so debilitating and so far on the other end of the spectrum that it just strikes me as in some ways a continuum. And it does help us understand why psychedelics have an impact on, all along the spectrum, sometimes in good ways, sometimes in risks to be aware of. Yeah.
Well, that's a good segue then into talking about psychedelics, because one of the things we think might be helpful about the psychedelic experience is how it sort of mixes up this balance between order and entropy. And for somebody who's maybe a little quote unquote too in touch with reality, it helps sort of disentangle that entrapment by reality, which gives you, if we sort of reference Robin Carhart Harris's work, this perhaps this ability to have your beliefs updated from sort of a bottom up direction, as opposed to having your tightly held beliefs interpreting from the top down, promoting psychological flexibility where there isn't any.
Yeah. So this makes me think of the original LSD days when Albert Hofmann at Sandoz Laboratories in Switzerland had his epic bicycle ride and psychedelic experience, if you will. We could read his trip report and point out the psychotic symptoms if we weren't pressed for time here today. But they started sending LSD around to psychiatrists, including a lot in North America, the US and Canada, saying, this is interesting. Here's a sample of a new medicine. You might use it, 1, in therapy, 2, as a model for schizophrenia in your research studies. Things were less regulated back then, obviously. So it's interesting to think of it in that context. And there are studies that explored it that way, but it's also fascinating to me to look at what happened when people were using it in a therapy context with this question of reality. So I'm thinking of one LSD study from back in the day that followed people having their first LSD experience back in the 60s, and showed that every one of them afterwards said that was transformative. But then it did all these instruments before and after. What transformed? And the ones they chose anyway were all negative for the most part, and not picking up on anything substantial. But where is this coming from that people feel? And then the one scale that like lit up as changing was the ways to live inventory, or something like that, where it was getting at questions like assessing someone's kind of self-imposed need to follow cultural rules of getting a corporate job and working a 9 to 5 and things like that. LSD busted that open. And so in a way, I think LSD was helping release people from the grasp of too much reality or being too over-focused on this subjective reality that we've gathered in and see the world through.
Yeah. That description sort of gave me a tangential thought. That using psychedelics, back in the 50s and 60s as a psychotomimetic, like you said, like a sort of a model for psychosis, it makes sense in some ways, given that there's the changes to sensation, perception, cognition, all that. But it's different than psychosis in the sense that an LSD experience can produce these insights and changes, and people will often reflect on those experiences, saying they were deeply meaningful, if not some of the most meaningful experiences of their lives. I don't know that you see that very often with regular psychotic episodes, right? People aren't, maybe they are, but it's less common for someone to look back on a brief psychotic episode and say, wow, that was really awesome. I'm glad I went through that.
So how I make sense of it in my little brain, in my subjective reality, is that the difference between psychedelic psychotic state and psychotic illness psychotic state is one big difference is you chose to take the psychedelic, or it is temporary, even if you didn't choose it. This will pass. And we talk about what you resist will persist and the need to surrender into an experience. No one's going to really surrender into schizophrenia or your first break. This is scary. You do not want that, right? And you chase it away and you throw meds at it. It's also something that's intrigued me by working in both the psychosis research and clinical field, and then the psychedelic research field is especially looking at the ancient wisdom of psychedelic practices. They would not treat psychosis emerging from psychedelic experiences, even if it were lasting for days or longer. They would not treat it with antipsychotics, right? They didn't have them, and it wasn't the approach. And I think I've mentioned this story on here before, but when I volunteered at my first ayahuasca retreat, I was medical support and one of the therapists for integration, and I brought my big medical bag and I got out there, and the medicine team would come from the jungle. They're nice to meet you, Reid. What's in that giant medical bag? Da 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 da. I've got meds for everything. He's like, thank you. You won't be needing that, and let's get to work. And then I heard the story of someone who, in the past year or two, had kind of a break during the ayahuasca ceremony and went running into the forest, the jungle, and was just screaming. And they safely followed and brought her back. But this psychosis lasted for at least 2 weeks, and they just took turns holding space in a little little home down the river, and would have an ibogaine doctor come and check in now and then and just let it run its course. And I got so intrigued by that. I was looking at old studies showing how maybe there is a link. There was at least some evidence to suggest that if you do not whack down psychosis in the ways we do, or chase it in the ways we do, there are some potentially improved outcomes. I'm not saying we have a way to do this. I'm just talking about the dilemma that exists of, when someone is experiencing a psychotic episode, I want to help them the best way I can. And if we have a medicine that's going to help with their symptoms without a big consequence, great, let's use it. And we need the safe space. We need the right therapeutic approaches. We need to hold the right kind of space too. But I think there may be more to the holding space and more to the safe container than we sometimes give credit to. And, some potential downsides to our Western approaches that we don't even fully appreciate.
Yeah. Yeah, I appreciate that nuance. And like you said, it can be a bit of a dilemma, in part because we know, looking at some research and prep for this episode about whether or not a substance use disorder like when people are young, can lead to or makes a person more vulnerable to a diagnosis of schizophrenia later in life. And this is not just a substance use disorder, but substance-induced psychosis. So,
Yeah.
just referencing one study here, 25% of people with substance-induced psychosis had a follow-up diagnosis of schizophrenia. And it was highest for people for whom the substance-induced psychosis came by using cannabis, so it's 34%. And then hallucinogens or psychedelics, 26%, amphetamines, 22%. So it is certainly possible that a substance-induced psychotic episode can put a person at greater risk for developing schizophrenia. But it's
Yeah.
nuanced, kind of like you were saying with your story.
So let's tease these apart because I think they're two different categories, related but important separate questions of what is the risk of psychosis in cannabis use? What is the risk of psychosis with psychedelic use? And why I want to rewind this is because cannabis use is often is often a regular practice. Someone engages in much more regular than psychedelic use. Not for everyone, right? And I think the frequency of use matters a lot in answering this question. And and when you insert a frequency variable of like, okay, what's the risk of psychosis taking one dose or taking a dose every day for a year? It's very different. But if you kind of try and collapse it into the best definition, about 1 in 200 cannabis users, regular users, will experience some kind of psychotic symptoms or episode, perhaps. And it's hard to get an exact comparison for psychedelics because it's not, I mean, because of definitions, because these are psychomimetic more so. But what is the risk of psychotic symptoms after your trip is over is kind of the question I'm interested in. And it's a much lower number than that. And some of the numbers I've seen might be 5 to 15 per thousand of like persisting psychosis for 2 days later. And the point is, we don't know, but there is a risk there. And that's why all of our psychedelic studies exclude people with a past history of psychosis. The ones we do anyway, the ones on the path, like some people are exploring, can psychedelics safely be used on like very small studies in psychosis? I think you've seen some of those studies recently, right?
Yeah. I mean, just because we don't have a ton of time, point taken about what you're saying, sort of the differences in the way people use cannabis and psychedelics, but also this idea of excluding people with psychotic illness from psychedelic studies because we don't want to put a mind that's already in entropy into more entropy necessarily is an understandable caution, right?
Yeah.
Understandable caution, but it's also not exactly the way things were being done back in the 50s. I'd found this really interesting reference to an old 1950s study of Bush and Johnson, where they were giving hospitalized patients with schizophrenia varying doses of LSD, some so-called microdoses, like low doses, 30 micrograms and higher. And they found that the LSD tended to help with some of the more negative symptoms. So they've got these fun little descriptions here, like age 24 female, schizophrenia, patient usually mute and withdrawn after medication, meaning LSD, writes letters and occasionally sings to herself, more alert. Or with a 47-year-old female, paranoid schizophrenia, speech is increased but becomes incoherent frequently with low doses of LSD, entered into ward activity and did drawing. So just interesting from, 70 years ago or so.
Those brave explorers, well, in recent years, I'd say the brave explorers who have studied it carefully, ethically, safely in these populations. Back then, it was more, this is a new medicine and not regulated, and also
just
research,
sort of thrown it at people.
Research was different back then. It was more of a Wild West. But yeah, that's I guess it's been a tricky one over the years, but thankfully, as we'd expect it to happen too, the restrictions going into studies do tend to loosen a bit as you're getting closer to potential approval. Like psilocybin early phase studies might not only exclude people with a personal history of schizophrenia, but or also a family history. and many studies still do. But as you get through phase 2 and especially phase 3 studies, where a medicine is getting closer to a real world population, you might let back in like the family history and whatnot. But that's a big factor because schizophrenia is one of the most genetic or heritable mental health conditions, about 70 to 80% attributable to genetic factors, where an average mental health condition would be about 50 to 60%. And so if you have twin studies, like identical twins, if one twin has it, there's about a 50% chance of the other twin having schizophrenia. If it's a fraternal twin, 10 to 15%. So,
Yeah.
And then you can also compute to estimate risks if you have a parent or sibling with schizophrenia. But those are very high risk states.
Yeah. So proceeding with caution again makes a lot of sense. I think there's some interesting theories about what we're learning about what psychedelics do in the brain that suggest that maybe they could be helpful for people with schizophrenia or psychosis. This sort of brain
Yeah,
resetting mechanisms and
especially
circuitry.
the negative symptoms, like you mentioned, that flattening is a
Mhm.
flat affect is a negative symptom. And if you start to have a smile again, like that medicine was doing something, of course we have the questions, what's it doing to your hallucinations and
Right.
if there are paranoid delusions, what happens, etc. But yeah, that is a fascinating question, remains to be answered with some interesting preliminary evidence.
It makes me excited for the future if we can get more precise with maybe even novel psychedelic compounds that
Yeah.
really help with synaptic neurogenesis, help with circuitry resetting, and that maybe we could leave some of the other things alone
Yeah.
in the brain of a person with psychosis
Mhm.
that psychedelics generally affect. But I think there's hope.
Yeah. And a couple, certainly, yeah, I think that's a good way to kind of wind things down. And maybe just a word of caution. Um, Another note on the cannabis front is that the studies have shown that high potency cannabis
Right.
THC concentrations have been increasing significantly as the market has expanded for recreational medical use, and people go to the dispensaries and are often filtering out and looking for more bang for their buck. But then they get the same cannabis that's twice as strong. It
Hmm.
can be twice as strong. They get that, and are they really using less? Or if recreationally, people are often just seeking more and more of it. But the point is, daily users of high potency cannabis are at about a 5x increased risk for developing a psychotic disorder. So that's something
Hmm.
to be aware of. If the risk is in the, say, low under 1% or in that ballpark, then that's one thing. But if it's an individual who is at high risk because there's a family member with it or any past kind of concern of symptoms in that individual, then that's where you know we're just urging caution. Like that's where this saying, I don't know where the saying comes from, but where I think it applies is check yourself before you wreck yourself. Like
Yes.
take a buddy along for the journey if you are exploring regular use of cannabis or psychedelics for that matter. And yeah.
Yeah, important caution. And a lot of these high potency THC containing, like high THC containing cannabis formulations or strains, often, they're reducing the CBD content as well. And I think I saw some research to suggest that CBD might actually be kind of potentially helpful for a lot of mental health conditions. So,
Yeah, there's a lot we don't know,
mhm.
but more being kind of discovered and understood as things progress. And I think there is an exponential expansion of our neuroscience understanding. I don't think we're going to get there and really answer the hard questions, but yeah, I think neuroscience is really having its day. And like we've talked about the past 2 episodes now, Stan Grof's prophecy of psychedelics being like a telescope is to astronomy is kind of playing out.
Yeah. Yeah. Well, thanks everybody for tolerating the breakneck speed of this particular episode. Covered a lot of ground in a short amount of time, but thanks, Reid. It's fun.
Thank you, Steve.
Psychedelic Therapy Frontiers is brought to you by Numinus, a mental wellness company committed to tackling the global mental health crisis by delivering best-in-class psychedelic-assisted therapies, contributing to the body of primary and clinical psychedelic research, and fostering healing through community connection and social responsibility. You can learn more about Numinus at numinus.com. That's Numinus.com. If you enjoyed the show today and you want to support us, here's how you do it. Rate and review the show on platforms like Apple Podcasts and Spotify. Subscribe to the Numinus YouTube channel, like the videos, and share it. Share the show or clips of the show with someone that you think will enjoy it. The content of this podcast does not constitute medical advice or mental health treatment. Consult with a medical or mental health professional if you believe you are in need of mental health treatment.